Hello, doctors. I'm Dr. Chris Rapoff of EZ QME, Continuing Education, and welcome to this week's presentation. Today, I'd like to discuss a symptomatic condition that is many times overlooked when we're assessing a painful condition involving the thoracic spine, and that is the T4 syndrome. T4 syndrome actually can be a very potentially painful condition, but its etiology is not well understood and oftentimes forgotten as we differentially diagnose a condition of the mid-back. Today, I'd like to provide you some clinical insights to this condition and also touch on how we can diagnose this condition in a patient or an examinee in a qualified medical evaluation. So let's get started. First, these are the following sources I reference when producing this presentation. I encourage you to explore these references if you'd like more in-depth understanding of our discussion today. First, what is T4 syndrome? Well, it's known as upper thoracic syndrome as well, and is a diagnosis of exclusion when all other diagnoses do not fit a clinical pattern. This condition is rare. It's a rare occurrence of symptoms involving upper limb paresthesia, weakness with reduced thoracic motion, and tenderness on palpation of the T4 vertebral area. It was originally theorized that these symptoms exist due to the sympathetic nerve fibers converging at T4. It is known that the head and the neck are provided with the sympathetic outflow from T1 to T4, and the upper trunk and extremities are thought to be supplied by T2 to T5, and there's an overlap there. So this could account for the symptoms in the head, the neck, and the upper extremities as well. Now, as you know, the thoracic spinal nerves mostly innervate the respiratory, the visceral, and the lower back areas. However, T1 and T2 do also provide some of the upper limb and are part of the brachial plexus. We do know that T4 syndrome is a rare occurrence with little high-quality evidence to prove it as a diagnosis. So caution must be used when diagnosing this as a primary pain driver. The prevalence of this condition is rare, and it's more common in females, approximately 3 to 4 times more common. The risk factors include poor posture, sedentary lifestyle, repetitive movements, hint, cumulative trauma injury, and thoracic spine stiffness. Now, given the anatomical complexity of thoracic and shoulder areas, the potential sources of pain in this region are pretty numerous. In the worst case scenarios, red flag questions to rule out long-standing visceral issues should be asked specifically regarding cardiac, respiratory, renal, gastroesophageal, and cancer. Now on to the characteristics in a clinical presentation. It is an exclusion diagnosis that I mentioned before. So once other issues have been excluded, then it may be indicative of a T4 syndrome. The symptoms may arise following a change in a normal routine, such as maybe a new job or a hobby. And these signs and symptoms could be the result of thoracic dysfunction and its influence on the sympathetic nervous system. A typical presentation includes paresthesia to the upper limbs and hands in a glove presentation, and this could be unilateral or bilateral, neck pain, headaches, upper limb pain, bilateral or unilateral, pain around the T4 area, scapular pain, reduced hand dexterity, heaviness in the upper extremities, swollen hands, thoracic spine stiffness, and tenderness on palpation of the T4 vertebral area. Less common symptoms include pain around the chest wall, worse pain at night, pain and deep breathing, and pain on coughing or sneezing. As you can see how this would be an exclusionary diagnosis because these conditions could be found in a number of different conditions that would have a different diagnosis as well. Well, diagnostic procedures, this is where it gets to be tricky because T4 syndrome is an exclusion diagnosis with actually no validated clinical criteria to assist in your diagnosing. Imaging is no aid in the diagnosis, but again, if you're using exclusionary diagnoses, this can help with ruling out other conditions. Subjective and objective assessments may also help to aid in excluding other diagnoses as well. Well, as with the testing or diagnostic procedures, examination procedures are virtually no different, as there's no real evidence about examinations that include T4 syndrome. Unfortunately, a great deal of the literature exists on shoulder pain, yet little exists in the area of periscapular or rib pain. So it can be concluded that the intervertebral joint around T4 is possibly hypomobile in patients with a T4 syndrome. So during your objective examination, it may be useful to assess a number of different things here, as I'm going to discuss. First of all, the overall observation of the patient or the examinee's posture, sitting, standing, and provocative movements throughout the exam. Thoracic active range of motion, cervical active range of motion, shoulder active range of motion. Then passive thoracic and cervical range of motion as well. You would assess shoulder and cervical strength and provide a neurological assessment where you would use potentially dermatomes, myotomes, and reflexes to determine whether the nerve root or peripheral nerve lesions were present. So we get to the differential diagnosis aspect of this condition, and this is where red flag questions should be asked extensively to the examinee to rule out any cardiac, respiratory, or visceral issues. And the thoracic pain is also common with cancer metastases, so prior to any manual therapy, be sure to rule out cancer as a cause of pain. Now, after the red flags are cleared, and it's then important to rule out other differential diagnoses, especially in potential T4 syndrome, as this is a rare condition, thus other diagnoses are more likely. So these can include, and as you'll notice, these are many of the differential diagnoses we encounter in a qualified medical evaluation of an examinee. So we would test for thoracic outlet syndrome, carpal tunnel syndrome, ulnar nerve entrapment, cervical disc disease or degeneration, visceral disease, neurological disease, fibromyalgia, myelopathy, complex regional pain syndrome, or cardiac disease. So let's discuss the medical management of this condition. First, after you exclude the conditions, including ruling out red flags and differential diagnosis, and pain management should then begin. Now, this should follow the standard ladder of analgesia, which basically is a minimal to general anesthesia. However, if neurological symptoms are present, it may be helpful to prescribe gabapentinoids, or if pain is ongoing, consider intramuscular injections of bupivacaine at the fourth thoracic spinal level. Physiotherapy and conservative management are also primary treatment options. So after the analgesia has been optimized, and if the pain is still an issue with functional deficits, physiotherapy is a primary treatment option for T4 syndrome. Now, this type of therapy, there are techniques that have been shown to affect really symptomatic relief for the individual. First of all, chiropractic or physiotherapy joint manipulation or mobilization techniques are basic in treating T4 syndrome. These mobilizations have been shown to have analgesic mechanisms due to their effect on the sympathetic nervous system. We also have soft tissue mobilization. Light pressure or gentle skin rolling technique have been shown to have an analgesic effect in the short term. We also want to address psychosocial factors in management of these anxieties and stresses that may be present. A graded exercise program would include thoracic and upper limb active and passive ranges of motion, trapezius and rhomboid stretches, gradual strengthening exercises, functional movement or mobilization, postural correction as required, and something called neurodynamic mobilization. It's also known as neurodynamics or mobilization, and it's a therapeutic technique that's used in physical therapy and rehabilitation. It focuses on improving the mobility and the function of the nervous system, which includes both the central and the peripheral nerves. Now, discussing outcome measures, well, no self report outcome measure has been validated for this specific condition. Any number of outcome measures would be appropriate for this patient population, and they would include a few here that I note. The patient specific functional scale, or the PSFS. This scale determines the functional status of an individual, and they're asked to report on the most important activities they are unable to perform and score them on an 11-point scale where 0 is not possible to carry out and 10 is possible to carry out with activity. A higher number means a better function. We also have the Neck Disability Index, and this questionnaire is a self-reported measurement that reports pain limitations in providing or performing daily work activities. This index can indicate how much the neck problems affect the daily activities. Also, the DASH, the disabilities of the arm, shoulder, and hand. And this questionnaire uses the 5-point Likert scale, which the patient can select an appropriate number of corresponding to his or her severity and functioning. And finally, we get to the prognosis of this condition. Generally, the recovery is favorable with appropriate management, as I discussed prior. Also, the challenges, though, that are present here are a misdiagnosis due to the overlapping symptoms with other conditions. And this is very important, again, to rule out red flags first and other conditions that are similar in kind and into the characteristics of the symptoms that they're experiencing. Okay, so in summary, T4 syndrome is described as a pattern of discomfort or pain that involves upper extremity paresthesia. It can be caused by thoracic hypomobility, but it can also have a sympathetic origin. Typical signs and symptoms include headaches, neck and arm pain, and potentially bilateral or unilateral stocking glove paresthesia. It is more likely to be a differential diagnosis, and the T4 syndrome should only be concluded once other conditions have been excluded. Chiropractic and physiotherapy is a primary treatment, along with other pharmacological management, and joint mobilization of the thoracic spine, soft tissue work, mobility exercises, and neurodynamic movements are all viable treatments and are best managed with a focus on reducing any of the potential psychosocial issues that may be involved at the same time. Well, doctors, here we have another rather obscure condition with symptoms that can mimic many other conditions that we commonly see in our everyday practice and a typical qualified medical evaluation. Now that we have something else to consider, examinee that possibly would have a T4 syndrome. Well, doctors, I'm Dr. Chris Rapoff, and I wanted to thank you for taking the time to join me in today's presentation. I hope you enjoyed it, and I do look forward to sharing other interesting subjects as they potentially relate to the examinee and a workers' compensation system. Until next time, thank you.